Hello and welcome to this lecture on neck pain with radiating pain. This is the fourth of the four-part series on the treatment-based classification examination lectures. And the first thing I think of when we talk about neck pain with radiating pain is that if it is radiating or traveling pain, most likely there's a neurological cause to the individual symptoms. And then if it's neurological, I'm thinking, well, when is a neurological exam warranted? So what do you have to do to, in addition to your other testing, for a neurological exam? And what I would say is if individuals present with signs of upper motor neuron problems, lower motor neuron or peripheral nerve entrapments, or any other atypical signs and symptoms that really don't match your standard musculoskeletal presentation, that's when I'm thinking about my neuro exam. Components of that exam are going to be dermatomes, myotomes, and reflexes, cranial nerve testing, upper motor neuron special testing. So that could be anything from your upper motor neuron special tests are going to be like a Babinski test. It can be a Hoffman's. It can be an inverted supinator sign. That sort of testing is going to help either rule in or rule out upper motor versus lower motor neuron problems. There is also some quick checks that you can do, or quick things to observe and look out for without doing a full test. But if you have some suspicion that they have a neurological problem of some sort, even if it's a peripheral nerve entrapment, it can help you make a better diagnosis if you do this testing. So some of those things to look out for, though, are going to be changes in muscle tone, changes in coordination, muscle wasting or some muscle atrophy, and then also gait ataxia. So if they have clear, just like difficulty balancing, or it looks like they have an uncoordinated gait pattern, those are all important things to look for. Additionally, age is important because we know cervical myelopathy is correlated with the person's age, so it's definitely a consideration. Other quick checks you can do and we cover those in the efficient examination for the cervical spine, is that looking at lower extremity myotomes by having them heel walk and toe walk, looks at L4 and S1 respectively. So there's quick checks you can do without doing all of these things. But as I mentioned, just to be safe and give the best diagnosis for the patient, I would recommend doing the majority of these tests. So when it comes to neck pain with radiating pain, the major tests that you should look at are going to be your cervical active range of motion, Sperling's, distraction, thoracic segmental mobility, and then muscle length testing. The one that we don't have up here, which we include later on, is going to be our upper limb tension tests for the median, ulnar, and radial nerves. And doing those three is going to help you determine what level of the neck may be involved. The first thing that I think of when I see these tests is the cluster for cervical radiculopathy, the four-part cluster. And that is going to be decreased cervical active range of motion into rotation. And then, so if you have less than 60 degrees to one side of rotation, that is a positive criteria for cervical radiculopathy. So we have 1, 2, and 3 here, a positive Sperling's test, a positive distraction test. And then number 4 would be the positive upper limb tension test for the median nerve. Those, per the research, have been highly correlated with cervical radiculopathy, and you can see how nicely it matches the treatment-based classification for individuals with neck pain and radiating pain. Some other testing that you do want to do is thoracic segmental mobility and thoracic active range of motion, because if the thoracic spine and especially the CT junction isn't moving well, it can create a mechanical irritation on the nerves that pass through that region. That's actually very personal to myself because I had venous thoracic outlet syndrome on my right side. So they removed my rib, my first rib up top, and they took out my scalenes. And for 2 or 3 years, I was okay afterwards, really no symptoms. But now, after I've been lifting more and I've really returned to all activities, I find myself having quite a bit of irritation down the back of my arm and then into my lateral elbow here. And it really wakes me up at night. And the main symptom I have is itchiness. So I'll get woken up with this really almost like a gnawing itchiness in my elbow. And if I press up in the upper trap region, it reproduces my symptoms. If I will hang out an extension and rotation on that side of my neck, it reproduces my symptoms. So even though the thoracic outlet syndrome for the vascular part was taken care of, I almost now have a secondary, either you could say cervical spine or TOS type presentation with more of the neurological symptoms. Now, it's not bad at all. Like, it is unfortunate whenever it happens, but I know what the factors are that make it better, and I know what makes it worse. And what's very surprising is that there are clear postures and positions that make my nerve pain worse, but stress, a lack of sleep, poor nutrition, all of those things, because it's radiating pain, it's nerve related pain, all of those directly impact the nervous system and contribute to my symptoms. So when I think of this category, I want you to go back to that cluster for cervical radiculopathy and then add in some of these other possible contributors that could cause some sort of nerve irritation. The last thing, will these clients have upper motor neuron or more lower motor neuron findings? You would expect more of the lower motor neuron because it's going to be either a nerve root or a peripheral nerve that's getting entrapped. And I'm hoping that I wouldn't see any upper motor neuron issues, more like a cervical myelopathy, because while we can treat those people, we know cervical myelopathy naturally progresses over time. And you also just want to make sure that if they have signs and symptoms of upper motor neuron issues, that you're having them also co-evaluated by a physician. Some of the seated special tests and assessment that you should do, or that you should look for, well, we talked about the Sperlings and then compression and distraction. So the difference between those two is that a Sperling's test is going to be at an angle versus straight down. When it's just a compression test, it's loading up the facet joints on both sides equally. And with Sperling's, you're loading up one side relatively and then compressing down, which in theory would decrease the space for that nerve root. Other things that I look for in the shoulder region would be decreased scapular rhythm, and that is just going to be clustered with my other findings. So individuals who have nerve irritation or just upper limb nerve tension that's consistent with their symptoms, they often will have poor scapular rhythm because muscles are firing in different ways due to the neurological compromise. And I say compromise just as that nerve is either getting tension or compression. I don't say that in a negative way. It's just the symptom that they're presenting with. Also, the first and second rib mobility assessment would be important. And the reason for that is the brachial plexus and the nerve roots, they run and wind all through that area. So for me, the subclavian vein runs between the first rib and the collarbone. So they took out my first rib to open up space there. The same thing happens with the neurological structures, where if the nerves as they're passing through the anterior and middle scalene on the first rib or the posterior scalene on the second rib, if there is hypertonicity, muscle shortness, etc., that can all lead to some nerve irritation and then correlate or connect with these symptoms that they have. One interesting point is that when you do the cervical distraction test, which you can do for this section, but distraction does relate to the person's symptoms. First of all, you can do that in sitting or supine, but just know that feeling good in that position is not a positive test. It needs to decrease and centralize their nerve-related complaints for that to be a positive test. Because distraction almost feels good on every person. So we need to make sure that we're being more specific and that it's directly taking away their symptoms. For the supine special tests, a main one to do, and this is not the picture here for the distraction test, but the main test is cervical distraction. And for this one, you can perform it in sitting, similar to the compression test. But what I would recommend is in supine, because you have more control and the patient's more relaxed. You're going to place your hands under the masseter processes and provide an axial distraction, so a straight distraction of the spine, of the cervical spine. And a positive test is going to be an alleviation of the peripheral symptoms. And also, this test can be performed in sitting, where it's the same position, but you're just lifting their head vertically. And what I would say is cluster the findings of this test with your other tests for sure. We do include the vertebral artery test here as well. The reason we include it here is that if you're going to be doing testing, if they're having neurological signs and symptoms, just to be safe, we think you should also perform the vertebral artery test to make sure that the patency of the artery is there. Now, with that being said, this test by itself doesn't have the best diagnostic accuracy. So we would highly recommend monitoring for the 5Ds and the 3Ns and then other signs of vertebral artery dysfunction in addition to just doing that test. But we have that test as a review and we have it in other review materials because we think having the vertebral artery problems in the back of your mind should always be there no matter what when you're working with cervical spine people. When it comes to adverse neural tension, this is what you're looking for when you perform those upper limb tension tests. So first of all, we all have some degree of neural tension. So if I take my arm and I depress my shoulder down and then I straighten my arm all the way out, I can feel what is neural tension along the median nerve there. Now, I'm not having any symptoms, so it has to reproduce my symptoms to be considered a positive test. Now, just because they have it, I want to know, does it recreate their pain? So the 3 criteria for positive tests on neural tension are going to be recreation of the primary pain, asymmetrical findings, which means it's going to be different on their symptomatic side versus their asymptomatic side. And then also altered symptoms by moving a distant component. So with the median nerve, if I'm here and I feel tension, let's say in my wrist right here, I want to move the shoulder and I want to see by elevating the shoulder, taking the depressive force off of it, if that changes the symptoms down below. It's got to be a structure that does not directly connect to the region. So if I just move the elbow here, I can't do it because there's muscles that run right through the hand all the way up to the elbow. It's got to be a distant and disconnected component from the original symptoms. As I mentioned, you should know that there's pertinent but not positive symptoms. So we know that a nerve can get irritated just as it runs through the pathway, and it doesn't have to be the symptoms that they're presenting with, and it doesn't even have to be a problem because we all have some level of it. Just know that neural tension is kind of a constant, just as we can stretch any muscle. Even the most flexible people can still stretch. Everyone's going to have some neural tension. We just want to know if it's pertinent to that person's case. An analogy that I like to use for this is that if the nerves are like garden hoses running through your body, and they have to wind around different things. Just as when you're watering your grass at home or watering the flowers, the hose travels through these little nooks and crannies, and the water is almost like the nerve output going through that. So if you have some compression in the thoracic outlet region, imagine that nerve or garden hose is getting slightly compressed, and then potentially, let's say it gets compressed through the bicep or at the carpal tunnel. All of those areas are opportunities for some nerve compression. If you're healthy and you're moving well and your biopsychosocial factors are low, then you probably won't have any nerve irritation. But if multiple things are adding up, that nerve can receive more and more compression, and its ability to innervate the appropriate outcome. Let's say it's your fingers in your hand for that median nerve and the sensation along that pathway. It's going to be decreased if that garden hose is getting compressed in too many spots. Lastly is the upper limb neural tension testing. And what we say is that there's several ways to perform these tests. Biggest thing for me is that you're consistent. So I want you to have the same steps every time so it's reproducible. One time, if you bias the shoulder first, but then the next time you don't bias the shoulder till the very end, you're not really going to know what is making a difference, or if they just have more freedom of movement in certain planes than others. So this is the biggest thing with neural tension testing, is that you as the practitioner follow the same pattern over and over again. When you're performing these tests, think about the nerve pathway more than anything, because that'll help direct where you're feeling tension at. And also it's going to cue you into, based on what their symptoms are, you know which nerve to test first, and that's going to help with efficiency. With myself, the symptoms kind of travel the top of my shoulder, wrap around the back of my arm, and then they stop right in the lateral elbow. I'm not thinking median nerve, and I'm not thinking ulnar nerve, because if it's the ulnar nerve, we know symptoms are going to be more medial. And if it's the median nerve, we know they're going to go down into the forearm more. So like through more of the anterior shoulder. By the sheer fact that it happens in the back of the arm and then also in the lateral elbow, it directly cues me in that the radial nerve and then also segments C5 to T1 are going to be what I'm looking at. So the patient's presentation is going to help dictate the efficiency of your upper limb tension testing exam. Any final points on this one? The consistency is key, knowing that you don't have to follow the same routine as the other people in the clinic, even though it probably would be best. Following your own routine of consistency is going to be key. And then for me personally, I would say anytime that someone's having vague symptoms is when I would always go back to the cervical spine and go back to the neck. So the other day I was working with someone who was having medial wrist pain, and as he was having medial wrist pain, it turns out that he was holding his hand in that position because he didn't want to stress the radial nerve on the other side. So it was a random pain, and I couldn't reproduce it just by stressing the TFCC area. So I did some other upper limb tension testing, and I was able to find a good amount of radial nerve tension. And after I mentioned that, he said, "Oh yes, I also have been having a lot of pain, like along the backside of my tricep." So I cleared up the radial nerve tension with a combination of manual therapy, dry needling, and also some nerve education. And that helped right away. That helped with his wrist pain, and it allowed him to carry his newborn son easier. So addressing the, you could say, unexplained distal causes with some radial nerve tension testing and then follow up with radial nerve glides and other manual therapy can have a pretty profound impact. So that is the neck pain with radiating pain lecture. Remember those criteria in relation to the 4-part cluster for cervical radiculopathy, and we'll see you in the treatment sections.